Дөрüşекеш, 1 секунд. 1 секунд. Hello, dear colleagues. How are you? My name is Mynzhylky Berdikhojayev and my colleague Davlet Шайкибекович. Қалайсыз аға? Қорықпай жата беріңіз, мен келдім. We are from Almaty, Kazakhstan, and the first case, as you have seen on the screen, just a second. Mynzhylky 2. Okay. Okay, let's discuss in the control room. Можно эту картинку. And today Madina is operating nurse, anesthesiology team supporting, and Evgeny, as usual, supporting the video streaming. And now you can see this is angiography from brachiocephalic trunk. Nothing clear. And then it's a vertebral artery on the right side, small kink on V1 segment, and intracranially it's look okay. The right side supraclinoid ICA is stenosed, and the A1 segment on the right side is hypoplastic. I will clarify the neurological symptoms in the operating room together with Davlet. And you can see there is a stenosis and some dilatation, and Davlet said it's look like ophthalmic artery origin, but for me it's look like paraclinoid aneurysm, because origin of the ICA looks here, and this is like aneurysm, or it might be also prestenotic dilatation, but for me it's clear it's aneurysm. Yes, it's aneurysm. It was no bleeding history. Small kink in the first segment. Нужно вот это поставить. Он на большом экране. Окей. Окей. Yes, there is some new findings, and we will see there is a slight stenosis supraclinoid. It's not critical. We will follow this stenosis, and the patient will be on double antiplatelet therapy. 19, and this segment is 23. It looks like it's not so severe. 2.5, 3.1 millimeter. Okay, let's measure the APs. 2.1. Okay. Till now we can follow this stenosis, and the left side vertebral artery is occluded. Yes, as you noticed, in our country and in neighboring countries, there is a lot of multifocal stenosis, multiple stenosis, and it's a quite endemic region for the stenosis. Okay, and then Davlet made a 3D rotational, and now, yes, it's clear. The orifice of ophthalmic here, aneurysm is here. For me, there is no doubt it's aneurysm. Oh, it's before the stenosis. 4.7. And also Davlet noticed there is a small aneurysm in MCA bifurcation. This one. Okay. I think something is going, but it's unusual to have. I think something is going nearby, but for me, it's like okay. Just a second. As it might be in fundibulum, it's interesting. And let's clarify the situation. And I think we need to do angiography like this with the plates. Yeah, Kastir. Just a second, like this. Okay, 1536. Okay. Patient under local anesthesia. The setting is 8 French sheaths, short one, and guiding is 8 French Hyperion coronary. Okay. And the angulation, we can discuss about angulation. It's very important when you plan to do intracranial stenosis. This angulation is very important. I will say why. And patient is 67, 66 years old. This angulation. Don't look for these millimeters. I want to show you just an angle. This angle. If this angle more than 90 degree, like here, the coronary balloon and coronary devices are navigating quite easily. And then the angulation might be like this, Even 90 degrees is quite okay, but if the angulation looks like this, it's just example. Then your balloon is going like this, and then it's very hard, nearly impossible to push the coronary devices in the supraclinoid segment. That's why very important to know this anatomy. Maybe somebody already wrote the paper about these measurements, but from my practice, this angulation is very important. When I see the lateral view angulation like this, then it's possible to use coronary stents with no problem. Okay, let's see the last angio. And Davlet is saying it's look like жировицы. Она детектор блайборда. Хорошо. Yes, the belly is a problem, and Davlet couldn't do 36-degree angulation like on 3D. And now he will rotate the detector in a horizontal position, and then it will be okay. Like oldu mu? Bir stage. Okay. Now he will do. Davlet will do angiography. Yes, it's look like infundibulum. It's very rare for MCA, but you can see it. For me, it's not infundibulum. It's coming from somewhere. Не похоже на воронку. Такое ощущение, что он где-то... For me, it's coming from somewhere. Okay. I think it's coming from here and then going like this. Okay, just a second. We have NPR, and then it's which one is which? I think this is coronal. Now we can do like this. In coronal, it's look like можно пока выключить. Just a second. Okay, and now it's more clear. We can see this segment, and there is artery is coming from this segment. Yes. Now it's clear for me. It's infundibulum. It's very important, huh? It's quite interesting. It's very rare, but it's possible. Yes, but second. Yes, it's infundibulum. You can see also here. Екіде 75 дейді. Қазір бір секунд. Единственное, что бер жағында аневризма тұр ғой, оны не істейміз? 275, 12. Жоқ, сразу стенд қоясақ. Бар ғой 275. Так, битик, мынамен кеңейтейік. Мынаны қояйық. И единственное, что она аневризманы не істейміз. Просто понаблюдаем. Поток вынос. Дұрыс қой. Может, пока стенос решим, а потом дальше посмотрим. Левая садовод. Yes, we are discussing what kind of stent we can use in this case. It's also possible to use Leo 3.5 25 for stenosis, and but I prefer to use coronary stent. Okay, I think it's better. Okay, let's do. And aneurysm we will follow. На які наші винос. Ну, поки троюсь. And aneurysm we will follow. Okay. Yeah, infundibulum. Okay. Что была тик? Yeah. We asked for coronary wire xenon blue, and was for coronary wires Xeon blue, and the balloon for pre-dilatation will be Camus 2 mm by 15. And the stand we are planning to place Ultimaster Nagomi 275 by 12. Okay, let's see. Okay, let's see. I just arrived from the airport and it was a little bit cloudy before approaching the airport. Экранды 20 сантиметр аяққа тартасаңыз. Okay. Ja, болады. И сәл 10 сантиметр артқа тартасаңыз. Қорықпай көзіңізді жауып жата беріңіз. Тарылған жері көрініп тұр. Симптомдар қандай болады?
Просто он сам обследуется.
Давление көтерген? Okay. The stenosis was found during the checkup. Checkup is checkup. And patient has a arterial hypertension and the diabetes. And I think we need to ask our interventional cardiology colleagues to do coronarography just after the stenting. Okay? Coronarography just a second. Қазір. Okay, no problem. I think no problem. We have distal access catheter. If it's needed, we can open. But no problem. And usually it's not problem. And I prefer for such anatomy to open the ballast guiding catheter or Neuromax. There is alternatives coming from different companies. Yes, and nowadays the Chinese companies very actively doing improvement on the devices and material. Devices and material, and yes, and also the DeepSeek is available. There is a lot of surprises in next coming years, including the DeepSeek and the other tools. Yes. Okay, we went up. It's very important. And might be we created some spasm. Let's see. You know that I'm really enjoying the work on Philips, because on working days I'm working in Astana, and the machine in Astana is Kennex in Phoenix, and it's quite complex machine, and for me the Philips is better. Huh? Okay, we created some spasm, no problem. First of all, I need to approach to the supraclinoid. Smart mask. Жоқ, не істеп кеттің? Жоқ, осы. Smart mask. Okay, the ophthalmic artery, when you don't want to go there, it's already in place. Okay, now I need to place my balloon, and after placing the balloon, we will take out the guiding till the point of no spasm. The nominal pressure is 6 millimeter. I think we can do 6. We can give 6. Just a second, and with the intracranial stenosis all the time. So, 6 millimeter. 6 атмосфера. Обезболивающий лорноксикам саласаңыздар. 6. 14 беріңіз. I'm asking Davlet to give 14. Now is 12 and now is 14. Все. Назад. Yes, it's very important to keep in mind. Еще раз. The balloon may move. This is point number 1, and point number 2. Balloon is not finishing at the marker. And you need to keep marker a bit proximal than the stenotic segment. Okay. It's very important. This is a 2.75 by 12 coronary stent. The name is Ultimaster Nagomi. And I have seen the paper came from our, I think it was Chinese paper published recently about the submaximal or nominal angioplasty in intracranial stenosis, and yes, there is no surprise. It's very important. Less complication in the group with nominal with submaximal angioplasty, and I think it should be the standard of the treatment of intracranial stenosis. You see how easily, we can say yes, it's easily. It's went to the supraclinoid segment. It's very important to take as a notice the angulation of гепарин. Кетті ма?
Қыздар, гепарин, 5 мың.
Да. Так, медленно. 6 атмосфер, да? To take to the notice the angulation of the ICA. Okay. Медленно. 6. Медленно. It's a Russian word. Slowly. And my teacher Shimon Maimon usually says in such moment, gently. It's a 6 atmospheres, and then we will give 6 vertical, 8 atmospheres. Stop, назад. I'm a little bit scary from the distal part. We don't need any problem with the distal ICA. There is no problem. It's a spasm. Oh, it's okay. Once again, hangi ön көрсетші? Назад. Вперед. Все хорошо. Енді оны атмосфер бер, медленно. Жай. Жай in Kazakh language. The meaning is the same like медленно. Он. Если напряжение высот, то ответил. Супер. Так, назад. Назад is back. In Kazakh language it will be артқа. Spasm. Yeah. Okay, now it's better. I will bring my balloon to the stenotic point. We don't need to expand distally. The proximal is okay. Так, енді медленно, жай 12 бер. Жай is slowly. Yes, and we had a couple of cases when we inflated the stand and then pulled the balloon, and sometimes it's attached to the stand and it might move the stand. Медленно, жай, 12. Yes, now it's better. Now the stenosis became less. The nominal diameter, nominal pressure is 11. Now we gave 12. And 12 is 279, 2.8. Назад? No. Okay, 2.8 is enough, I think. And this stand could be inflated till 4.5 millimeter. It's very good stand, huh? There is a remaining stenosis. Okay. Now we can see clearly the aneurysm. And the stent is not opposed in proximal part, and the artery diameter is only 3.5 millimeter. Так, which 12 вертх, да? Дистальный жағы жақсы ғой. Так, қайтан 13 беріп көрші. Okay, now I asked Davlet to give a 13 atmospheres. Напряжение болса тоқтай сал. 13, да? Нормально? Все, тарт. Okay, now we give 13 atmospheres. And yes, the balloon could be attached to the stand. It's very important to do everything gently. Так, енді 22 бересің. Медленно 22 бересің. Еш нәрсе болмайды. 22. We'll give slowly 22 atmospheres. On 22 it will be nearly 3 millimeter. So stop. It was 22. It was 20. 20. It's nearly 3 millimeter. Okay. We are keeping in mind there is also paraclinoid aneurysm. Okay, now it's better. It's more opened, but still there is a place to inflate. Okay, I'm not sure we need to do something with the aneurysm. Just a second. Now we have this touch screen model, and okay, this aneurysm is quite small. This is infundibulum. There is a PCOM is coming. This will follow. No need to touch. Okay. Шарм алып бір үрлейміз әлде жетеді ме? Ана жерде үрлейміз тағы да жетеді ме? It's a little bit luft. Half millimeter. Шкафты ашсаңызшы. Жоқ, керек жоқ. Болар бітіре салайық. I think the perfect is enemy of better, and when we'll deflate this till the nominal diameter, there is a possible risk of complications. That's why, if Davlet agree with me, we can finish on this step, okay? Yes, Davlet is agreeing with me. Yes, all the time the perfect is enemy of better. And we need to keep in mind we're treating the patient, not the image. Okay, the stenotic segment now much more better. Okay, and we are happy. We have touch screen module, and we can do everything from the control from the operating room, and we are happy. There is also some difference, but thanks to Rene and half T stenting, if we will leave like this, there is no problem. Thanks to half T strategy, if something in the lumen 2.4, it was 1.4, and now it's nearly 2.1 millimeter. I think it's good. Let's see how much it was before. At the beginning, 1.4, and this was also the same. 0.7 millimeter is quite okay. It's less percent of stenosis, but also there is no complication. Okay. Now I will ask Davlet to do control CT and the coronarography. We will ask our colleagues. Okay, let's wait for the control CT.
Madina.
Okay, just a second. Now it's better. Okay. Аға қалайсыз?
Жақсы өте жақсы.
Стентіңізді қойып қойдық, құтты болсын. Қазір жүрегіңізді тексере салайық. Сізде коронарография болған жоқ қой?
Болған жоқ.
Тексере салайық, өйткені мидың бірнеше тамырында стеноз бар да. Сондықтан бір тексеру керек. Аға, жақсы. Okay, patient is okay. And now we will ask our interventional cardiology colleagues to do diagnostic coronarography. It's advantage of working in a multidisciplinary hospital. Multidisciplinary hospital, yes. We have mono-profile hospitals for some kind of pathologies. It's a Soviet system, post-Soviet system, but the Barrow Institute also, the neurological institute. Yes, Barrow Institute in Arizona, neurosurgical institute. We have cardiac surgery center in Astana. We have neurosurgery center in Astana. We have traumatology and orthopedic center. Okay. Какие пациентки утро, да? Да, конечно. Also the one emergency case in city hospital, and the patient's relatives asked to treat her in our department, and now we are organizing the transportation from city hospital to our presidential hospital. Okay. The color of the lights in the operating room is the color of Kazakh flag, and I like this color. Okay, CT is ready. Можно КТ поставить. Okay. Yes, the stent is in place. Everything is okay. Now it will be coronarography. I think it's not so interesting, or we can keep the transmission. Okay, we will keep the transmission, but I will switch off my voice, and Evgeny will finish when Davlet will say everything is okay with thumbs up. Okay.